All right. Hello, everybody. Thank you for coming today. Just wanted to make a couple announcements before we introduce Dr. Abushanab today. Make sure to join our email listserv. You can sign up on our website. Make sure to follow us on our Instagram at ShellcastMed and follow us on LinkedIn as well and list us as one of your experiences. Everything is in the link tree in our bio, so make sure to check that out. But without further ado, we want to introduce Dr. Abushanab today. He is an oral and maxillofacial surgeon. And if you're not familiar, they are dentists who are also trained in the medical field as well as surgery. They hold degrees in both dentistry and medicine. Dr. Abushanab was a resident in the OMFS program at Rutgers University and graduated from dental school in 2018. OMFS is super unique and fascinating and a lot more common than you would think. So we're super excited for him to share his experiences and his path. So without further ado, you can take it away.
All right, Megdi, thank you for inviting me to give this presentation. I'm so excited to share with you all more about my favorite fields in medicine and dentistry. So you'll see it delves into both. And it is a mouthful, oral and maxillofacial surgery. And it would be easier if they would just abbreviate it to oral and facial surgery, because that's really would describe most what we would do in our scope of practice. There's a lot of overlap between ENT and plastics, as well as dentistry, of course. So, okay. So why address medical and dental students? The idea is to initiate a lifelong relationship with professional colleagues. One day we're all going to be working in the same hospital, interacting with each other, asking for consultations, referrals. So it's important that you understand this field and all that we are capable of doing, and so that you can, identify the problems your patients have and know who to refer them to. So that goes along with educating future colleagues, reinforcing traditional scope of OMFS is both dentoalveolar, which is dealing with the teeth, implants, or replace a titanium screw to basically bring the teeth back. Now we have that ability, TMJ, and orthognathic surgery, which we'll go into a little bit more about what that is for those of you that don't know. But my primary goal when I started my page and coming on to present today is to really increase the awareness of the full scope of OMFS practice. That's oral maxillofacial surgery, encompasses really anything in the head and neck, including the nose, ears, and neck. And we go down and do bone grafting from the hip, as you'll see in a little bit. Okay, so also, of course, the goal of this presentation is to encourage and provide direction for those interested in OMFS as a career. Okay. So there's 101 training programs in the US, 55 are 4-year programs and 46 6-year programs. There's about 1,173 residents in oral surgery programs. 58% are in the single degree program and 42% in the dual degree program. And it's estimated that 246 residents will complete their training by 2019. So about a quarter of all OMFSs hold an MD degree as well as the DMD degree. So they both have an MD and a DMD. So they function under medical and dental licenses, but that's not everyone, as I'll go a little bit deeper into what that means. So the 4-year OMFS programs and the 6-year MD integrated program, the real difference is just the 2 years. Extra would be basically the 3rd and 4th year of medical school. In terms of the core 4 years, the surgical training is the same, and they're both required to meet the same standards. For the 6-year MD program, they're required to take the medical school step 1 boards upon acceptance into the program, and they must pass, of course. For the 4-year OMFS, they don't have to do that exam, but we take an exam called the comprehensive basic science exam, which is an abbreviated version of the step one. It's, I think, 1 or 2 sections less, but it's essentially the same questions. And it's a weighted score from 1 to 100, scaled. And basically, a score of 70 or higher equates pass on the USMLE step one. So in terms of the rotations, like I mentioned, they're more or less the same between both 4 and 6 year track. We do rotations with internal medicine, cardiology and pulmonology, infectious diseases, intensive care and critical care, both, specifically the surgical ICU. As far as surgical training goes, we do rotations with general surgery, vascular surgery, ENT, plastic surgery, orthopedic surgery, and anesthesia. And of course, there's variations within the different programs, and whether it's a 4-year or 6-year, sometimes they may have, for example, at the Rutgers, we don't do the orthopedic surgery rotation, but other programs may. And this is something that's very unique to oral surgery, oral maxillofacial surgery, is that we're the only specialty aside from anesthesia with such formal training in general anesthesia. We do a minimum of 6 months of training, 1 month of which has to be strictly pediatric anesthesia. And we're in the operating room as the main anesthesia provider. Our attending comes in for intubation, and they leave us in the room and they just come back for extubation. We're treated just like any of the other anesthesia residents. We take call with them. We're running the ORs for any number of procedures that's going on in the hospital. Like I said, they utilize us as one of their own residents for 6 months, half a year. So it's extensive training, I think more than any other specialty aside from general anesthesia, of course. Or sorry, just from anesthesia. So OMFS are also experts in pain and anxiety control. Like I was mentioning to the guys before, a lot of times we do single provider anesthesia in the office setting, doing conscious sedation, deep sedation, in usually healthy patients, to control the pain and anxiety for wisdom teeth extractions and implant procedures that are done usually in the office setting. So yeah, like I mentioned, the OMFS administers safe and effective anesthesia service in the dental office and ambulatory setting. So what does the scope of practice entail rather? The top left corner, dentoalveolar. And you'll see that includes third molars, dental implants, pre-prosthetic surgery, orthodontic exposure, apicoectomies, and tissue grafts. In the middle to left column, there's pathology and infections. You can see in this tongue picture, that's cancer. There's bone grafting and for reconstruction, trauma, cleft lip and palate, TMJ, both reconstruction and rehabilitation and relief, as well as cosmetics. These are all the different fields within the scope of oral and maxillofacial surgery. And throughout my talk today, I'll be going deeper into each of these categories. So the dentoalveolar, I mentioned those before. This is really the bread and butter for most oral and maxillofacial surgeons. Third molar removals, impacted, usually stuck in bone. The top molars, usually approximating the sinus, with the risk of sinus exposure upon removal. You have to know how to handle that complication. Usually we take, fat from the buccal fat pad to cover the oral and antral communication. And then for the lower molars, there's risk of damage to the inferior alveolar nerve, which supplies feeling to the lower lip, gum, chin, and can be very, problematic for patients if they have an injury to this nerve. There are specialists in the field that specialize in repair of the inferior alveolar nerve, as well as the lingual nerve. And that's kind of micro-special or like subspecialty within OMFS. And our program director, Dr. Zaccardi, is one of the big names in the field as well. So this is a case from my Instagram page as well that we saw in the clinic. I shared this for Valentine's Day. We call these kissing molars because they're facing each other. These are, both the second and third molars are impacted in this case, and there's a cyst associated with them, and that's expanding and causing, this can be problematic because it compromises the lower jaw and can cause fracture of the jaw. So after this patient had these teeth removed, we actually had to wire him shut to prevent him from fracturing his jaw while the area filled in with bone. Usually took him out of maxillomandibular fixation and wired the mouth shut after about 2 to 4 weeks. So there's some more third molar cases. These are orthodontic exposures. Basically, if you look in the top jaw, let me use this pointer here. Here we go. This is a canine. It's the sharpest tooth in the top, in the maxilla. We call it the canine. Can be impacted and stuck in the roof of the mouth usually. And in order to bring this in, what we do is we expose it by laying a flap and removing some bone, and then we attach a little bracket, an orthodontic bracket, just like you put on for braces. We attach it to the tooth and then run a gold chain that we attach to the wire. That way the orthodontist will use that gold chain to slowly put traction on the canine to bring it into the mouth. So basically guide it from the position within the bone out. So, that's it right there. And this is the flap, the palatal flap, where we, then remove the bone. And let me see if we have, there we go. There's the orthodontic bracket with the gold chain that we attach to the orthodontic wires. And we suture everything back. And this one's also from my page here. I wanted to try to, let's share this. So this is a case of, both tooth number 6 and 11, both canines in the maxilla had to be exposed. And then you see how we tie the silk suture to the bracket, to the wire. And let me see if this will play. And it's very important with these cases to make sure that the bracket is attached firmly, because a lot of times it can come off. So you want to make sure that you can move your patient's head. That's how tight the bond has to be. Make sure that you don't have to redo the case. Okay. All right, so this is mandibular tori. This is a normal variation of anatomy where there's bone, basically usually under the tongue side, and we use a mallet and chisel to remove it. If it's a nuisance to patients, sometimes they'll get food stuck in there. It can be an annoyance, or usually this is more a problem for patients after they lose all their teeth and become edentulous. They need a denture made. This interferes with the denture fabrication. So oftentimes we'll need to remove this in order to facilitate denture fabrication. But now the day of implants is, a lot of our patients are choosing that option. So these surgeries are not as common anymore. This is another one that isn't as common anymore due to implant surgery as well. This is a tooth that had a root canal done and then still failed, still has an infection. You could see right here. And what an apicoectomy is basically uncovering the bone and removing the infection from the bottom, cutting the root tip off, cleaning out the infection, and sealing it from the bottom, usually with the material like amalgam or any MTA or any other material to basically seal off bacteria and clean it off. And this will fill in with bone. And the patients like this because they get to keep their tooth. It's really a last-ditch effort to save the tooth. If this fails, then the tooth is basically doomed to extraction. And then typically we'd bone graft it and come back and place an implant, or if the site is amenable, we can place an implant at the same time. And there's been a lot of advancements in the field of immediate implants. So now getting to the little bit more fun stuff, this is distraction osteogenesis. This can be used for a variety of things. In this case, this particular case, they are applying this distractor appliance, which the patient turns daily to advance the bone slowly in order to gain height for implant placement. The idea is that you want to avoid the inferior alveolar nerve that runs through here. So if it's too little of a height, you can't place implants there. So this is one option to gain height, but it's used more often now in craniofacial surgery for patients, like with Pierre Robin sequence. So dental implants, this is really also taken over as the bread and butter for the oral surgeon. This is basically giving us the ability to bring teeth back to life. This patient lost this tooth here. And what it is basically a titanium screw that goes in the place of that tooth. And after 2 to 3 months or 3 to 4 months of healing, a crown can be attached to this titanium screw, and you wouldn't know the difference between any of the other teeth if you have a good restoring dentist. So it's really a unique and great way to give patients their smile back. Here it is radiographically. And there you go. That doesn't look as good as some of the other work I've seen. This is the sinus lifting procedure. Again, this is another one of those procedures that's done to facilitate implant placement, but this is in the maxilla, the upper jaw. Usually we run into the problem of the sinuses. I'll show this picture here. These are your sinuses, the air-filled pockets behind, allow us to warm air, and for phonation, for speaking, are important. But over time, you get pneumatization of the sinus into these edentulous spaces. This patient lost his tooth for quite some time. And what happened is the sinus filled in that space. And now we have 3 millimeters of bone left. Not enough bone. You need a minimum of 10 millimeters to get an 8 millimeter implant. Or, there's arguments as to the specifics. But what's nice with these procedures is that we kind of reflect the gum tissue, and we tease the sinus membrane without perforating it. It's a very thin, 1 millimeter thin membrane that you have to gently tease and then fill in with bone. And then we close and come back in usually somewhere between 4 to 6 months to place an implant. So, and I'll show you what that procedure looks like. And here I'm asking the patient to breathe in and out, and you can see the sinus membrane going in and out. That means that it's intact and there's no perforation. We don't want a perforation because we want any of our bone graft material to go into the sinus and cause a sinus infection. So for that reason, it's very important to maintain the integrity of the Schneiderlin membrane. This is another option for patients that have the very little to no bone in the maxilla. We do zygoma implants now, which basically extend far enough into the cheekbone and engages the cheekbone, this nice dense cortical bone. You could see these being what they look like here after their placement. And sometimes the patient can be restored with a temporary prosthesis the day of placement. That's how sturdy these implants are, and really a great option for patients that are missing bone height in the maxilla, for being edentulous or without teeth for a long period of time. What the body tends to do is dissolve what it doesn't use, so basically decreases the amount of bone available for implant placements. Here you go. These are the prostheses. This is what it looks like on the patient. And it's not just about restoring the teeth, because what this does is also improve the facial profile of the patients, especially from a lateral view. I don't think I have one here, but it's really a life-changing surgery. The patients feel young again. They feel empowered to smile, and it's really life-changing and amazing what we can do these days. So, disease pathology, that includes surgical and medical management of infections, as well as benign pathology, malignant pathology, and other miscellaneous disorders. I think that's a salivary stone being shown there. So we'll start with infections. This is what happens when patients don't listen to us and leave a tooth that's infected for too long in the mouth, and over time the infection eats its way through the bone and into the dangerous spaces. Here this is going submandibular as well as submental appears, and this can cause an airway compromise. It can push up on the back of the tongue and close the airway, and this is really one of the medical emergencies that we manage. This patient had to be intubated due to that risk. And that's another reason why we train with anesthesia for 6 months and have to be very good at intubations and managing complications like this. This is debridement of the infection, and usually this includes incision and drainage and debridement. Of course, culturing the bacteria, and this is placement of a drain at the end to ensure, and usually these patients stay in the hospital receiving IV antibiotics until the cultures return with more specific antibiotics, and we consistently monitor, the CBC and BMP and manage the patients while they're in the hospital onto our service. Okay, this is an example of benign pathology. A lot of the times we deal with ameloblastomas and OKCs that can be very destructive, even though they are benign. They still can cause loss of the jaw if they continue to expand. As you can see here, they're eating away at the roots of the teeth and pushing away vital structures, including the inferior alveolar nerve. And this is a small benign pathology. I mean, I've seen much bigger where we required resection of either half the jaw or the entire lower jaw. And they can occur as well in the upper jaw, requiring reconstruction of the whole lower jaw. And oftentimes, depending on the size of the defect, we reconstruct it. After resection, we place a plate, a reconstruction plate, for 6 months, and depending on obviously the pathology, and then we come back and we fill in the bone we take bone from the iliac crest and the hip, and put it to rebuild the bone there. And if the defect is too large, it requires microvascular surgery and fibula free flap, as well as other sites. But those are the two favorites. This is an example of oral cancer. We play a vital role, including dentists in general as well. Should be conducting oral cancer screenings on all their patients, looking at the sites. A lot of patients don't even know oral cancer is a thing. Obviously, smoking and drinking are risk factors, but it can happen to anyone. So definitely encourage, all my colleagues to do these screenings on every patient, check the palate, check the under the tongue, floor of the mouth, tonsils, see any evidence of cancer or something that can be questionable, require biopsy, and then further workup and management, of course. So This is a case that I had during residency. This patient presented with this, just looks ulcerated. You know, you might not think much of this when you see it, but biopsied and indeed came back as squamous cell carcinoma, requiring the patient to have a resection and neck dissection. So after the removal, this comes the reconstructive surgery, which, like we talked about, includes the bone grafting, as well as implants, local and rotational flaps, free tissue transfer with microvascular anastomosis, the free flap, usually from the fibula. We can also take it from the scaphoid and various other places as well. So bone grafting, here you have a case of a patient that lost half their jaw, likely due to trauma. And this is an example of a clavarial bone harvest where we actually harvested bone from the skull, and they cut it into pieces and stacked it here. They went in through the neck. This is a incision right under the neck, and you reflect the bone. The idea is to keep the oral cavity, which is a dirty environment, separated from the bone graft. And that's why we go through an extraoral approach to keep the intraoral site closed and non-communicating with the bone graft. It ensures its success. And usually we cover this with a membrane of some sort and fixation with titanium plates and screws. And then we close it and leave it our site to heal and come back and place implants is typically the plan. Here it is. This is after uncovery after 6 months, implants placed. Here are the implants, healing abutments. These are just screws that are connected to the implant. They allow the soft tissue to heal around it. And here it gave the necessary height for the prosthesis. These are examples of local and rotational flaps. They would do, some plastic and reconstructive surgery. This patient here. We did actually, let me go back to that, but we did a case where a patient had the tip of his nose bit off by a pit bull, and we did a flap to basically reconstruct the site. It was a pedicled flap that remained, pedicled. I don't have a picture here. That required, this is a free tissue transfer, so it's not pedicled. Okay, so this is from looks like the anterior lateral thigh. Okay, so maxillofacial trauma, this starts as basic as the dentoalveolar injuries, the patients, knocking some of their teeth, to skeletal injuries, really anywhere, like I mentioned, in the midface and mandible, including the nose, orbital floor, maxilla, zygoma, and obviously the mandible more often than not. Soft tissue injuries, like I mentioned, with the patient, dog bites, fights, patients with split lips. These are all patients that we see in the emergency room and get called for by our emergency medicine colleagues. We also receive ATLS certification, and in our program, we rotate with trauma service for 2 months, seeing all kinds of trauma, not just maxillofacial, as part of our rotation and training. This is a dentoalveolar injury. This patient must, either fell on their face forward or a horse kicked their tooth. I've had a patient, a horse kicked their tooth out, and they require, sometimes if they're lucky enough and the tooth isn't knocked out, they can just get a splint, similar to this, but now we'd use composite, and then a wire through there to stabilize the segment and basically half the time it heals, the other half the time the teeth require extraction and replacements with implants. This is an example of a mandible fracture, lower jaw broken, anywhere between fights, usually domestic violence, motor vehicle accidents can all lead to this. Sports injuries. One of the oral surgeons I worked for, he was the oral surgeon for the Rangers, and we saw some of the Rangers players come in with either mandible fractures or knocked out teeth. This is a patient that I saw in the emergency room with a motorcycle accident, fracturing his lower jaws in 3 pieces, his upper jaw, and luckily for him, it's just the part of the bone encasing the teeth. But I have a picture here of what this looks like. And by the way, if you're not following my Instagram, it's all day OMFS, like all day, all night OMFS for oral maxillofacial surgery. Please give me a follow. And if you want to learn and see more of these cool cases, this is what the guy looked like coming in. It's a big mess right here. It's actually hard to see. It kind of looks like he has 2 mouths, but this is actually a laceration right under the nose and above the lip. So that was one of the craziest things I've seen on call. Okay, so the mid-face fractures, like I just mentioned, including the orbital floor, the zygoma, as well as the frontal bone. We also repair this patient. Looks like they had a nasal bone fractures, of course. This one's an NOE, so nasal, orbital, and ethmoidal fracture that was reconstructed with a titanium plate to give the nose the projection back. Here you could see all the fractured nasal bones basically crushed. I've done a lot of just the simple nasal bone fractures or septal fractures that you close reduce in the ED under just local anesthesia. Those are not fun. With this patient, a much more extensive injury and requiring multiple plates, titanium plates and screws, and usually we do a calvarial bone harvest to get this bone here to give that projection back. As you can see here, give a nice projection of the nose back. So even though it's a trauma patient, it's still, cosmetic. Everything we do is to give the patient their confidence and their smile back. It's an example of soft tissue injury, likely a dog bite, requiring multiple rotational flaps. And you can see the final product here. And this patient will likely receive some microdermabrasion and scar revisions. We also do Z-plasties and any kind of facial cosmetic plastic surgery, just as well as any of our other colleagues. We take call every 3rd day with at our hospital. We alternate with ENT and plastics for facial trauma. So, on a Monday, this could go to plastic surgery, and on a Wednesday, this could come to us. So both specialties are well equipped to handle this. It's another example. Soft tissue injury requiring facial flaps. So we also treat craniofacial disorders and TMJ. So that includes orthognathic surgery, obstructive sleep apnea, cleft lip and palate, craniofacial disorders, as well as TMJ pain and dysfunction. So this is the orthognathic surgery. Personally, this is the reason why I joined, kind of made oral maxillofacial surgery my goals. My mentor, Dr. Markowitz, shadowed him in the operating room one day in these surgeries to correct facial deformities. And I saw them do this in the operating room. Down fracture of the maxilla, basically the upper jaw becomes a free-floating segment, so attached obviously to the palate still, but it can be repositioned into the proper position. Here you can see this patient has a cant the upper jaw, and that was corrected. And there are some this is deviation. See, the facial midlines are off. These are patients with, congenital dentofacial deformities. They're born with this deformity, and we're, especially privileged to and give them, a normal facial profile, and as well as this also hinders, the patient's confidence. A lot of times these are teenagers, and it hinders it psychologically, as well as influences on speech and mastication, the ability to eat, and even if left untreated, can cause TMJ problems in the future. So definitely one of the most rewarding, life-changing surgeries that we do. And personally, the reason why I pursued oral maxillofacial surgery. You can see here the difference, especially here in the lateral view. And that also includes, chin. You can place chin implant. We can place chin implants, or even do a sliding genioplasty, which involves cutting the chin bone and moving it forward and attaching it with, titanium plates and screws, and it gives the projection as well. This patient had likely a mandibular advancement, includes cutting the lower jaw, the mandible, and then moving that forward and fixing it with titanium plates and screws. And we work in conjunction with our orthodontic friends in setting the patients up to maximize the benefits of the surgery and to achieve the perfect result like this. So, obstructive sleep apnea, it's the silent killer for a lot of patients. A lot of people don't know they have this. It increases as we age, as we get more, add fat to our body, increase in BMI. This becomes a problem. And the gold standard is actually if the patient can't handle, can't tolerate a BiPAP machine at home, the gold standard is maxillo and mandibular fixation. So all that means is moving the upper and lower jaw forward and basically increasing that airspace. What happens, that airspace is narrowed, and when the patient lies down to sleep, this collapses and cuts off oxygen supply at night when the person's sleeping, and can lead to hypertension, and is a silent killer for many patients. So this is the gold standard. Is actually, these patients are very happy afterwards, especially being able to breathe and just feel more energized during the day. TMJ disorders. This is the temporomandibular joint, basically the hinge. It's a ball and socket hinge separated by a disc at the base of the skull, the lower jaw where that hinges. Variations in the procedures can be from open joints, where we open the joint like this and repair any deformities that may be there, as well as arthroscopic. It's very similar to anything you can do, what our orthopedic colleagues do to knees. Arthroscopic and arthrocentesis, looking into the joint and flushing it with fluids and to flush out the inflammatory mediators. And oftentimes we inject the joint with a steroid, hyaluronic acid, as well as some pain medication to help give the patients relief. And this really does work. It can solve the problem for most patients. If there's very select cases, but we can, oftentimes we need to do a total joint replacement. Requires replacing the whole jaw as well as the cranial base component. Oftentimes needs to be flattened out or removed and replaced with titanium and PTFE material, as well as to reconstruct the joint. And again, it's similar to a knee replacement. This is for patients with joint issues that have, there's certain indications, of course, but certain patients need this, unfortunately. There's a patient that we treated that had fallen as a kid in Brazil and fractured both his condyles. They attempted to kind of repair it multiple times, or they left him in maxillomandibular fixation, so wired shut for too long, ended up fusing his the jawbone, so he wasn't able to open anymore, and he required total joint replacement. Unfortunately, this is not that patient. This is an example of the total joint replacement. And this patient had a pathology in OKC that was growing in the joint that we removed. This is the CT scan. This is the 3D modeling. This is really kind of amazing what we're able to do nowadays with virtual surgical planning and printing of 3D models and patient-specific implants. This is a custom prosthesis, custom joint. It maps out the patient's nerve, maps out exactly where the screws have to go, how much removal, highlighted in red there, of the bone is necessary. This is the prosthesis in action. You can see this is the kind of ball and socket movement. This is where we're manipulating the patient's lower jaw, opening and closing it to ensure proper function. And this is another life-changing surgery that we do. Cleft lip and palate. We are also capable of doing these procedures. Oftentimes we get called as soon as the baby is born in our hospital to see the patients. As less than a day old is when they first consult us, and we have to assess the extent of the cleft, if it includes the palate or it's just isolated to the lip. Oftentimes, or sometimes, these can be associated with syndromic patients, and they have to be evaluated by all the different medical teams at the hospital, as well as a geneticist. It's really a multi-specialty approach to these patients. We're also privileged to have Dr. Aziz in our program. He does a cleft lip and palate mission trip to Bangladesh every year, actually twice a year. That's been halted due to COVID these past couple of years, but hopefully I'd be excited to join him on those trips because these are truly life-changing surgeries, and it's really amazing the results we can accomplish. This is a patient with the cleft palate, and then to manipulation of the tissue and local flaps, you're able to achieve closure, and that really plays a role in the patient's speech and ability to feed. And this is the last but not least specialty scope within the oral surgery specialties: cosmetic surgery. Any facial cosmetics is within our realm. Blepharoplasties, for patients with baggy eyes, you can remove that and augment the areas to give the patient a nice cosmetic result, as well as full facelifts, lip augmentation through fillers or the patient's own fat, rhinoplasties, cosmetic and usually post-traumatic. After a trauma, the patient wants to correct the nose, and we are able to achieve results just as well as any of our plastic surgery colleagues. Neck lifts and Botox. You can see here the patients, increasingly aware of social media, of their, facial profiles and want to seek advancements. So we can offer them all these services as well. So careers in oral and maxillofacial surgery, what kind of lifestyle, what are the next steps for those of you applying? What is the CBSE? I briefly talked about that. So the oral maxillofacial surgery lifestyle is the best. You get to delve a little bit both in dentistry and medicine. You can, be the owner of your practice and have any desirable schedule, work as many days of the week as you want, but most oral surgeons will tell you this is not true. You end up, a lot of times we're all workaholics and we love what we do, and we choose to work more often than not. But you get diverse practice opportunities, both group practice or if doctors just want to do their own private practice patients in office setting, the dentoalveolar surgeries, they can do that. If they want to call at a hospital and have privileges and take trauma call and see all those cases, they have that opportunity as well. It's a dynamic profession, like I mentioned, about all the advancements in 3D printing and virtual planning, both implants and orthognathic surgery, TMJ reconstruction. You also have we have the opportunity to make a lasting difference in a patient's life. Like I mentioned, all those life-changing surgeries that we are capable of doing. Well respected and well compensated. I think it's one of the highest paying specialties in dentistry. I think it's one of the highest paying specialties, even I think it's just under plastic surgery. So definitely you can make whatever you want of it. Residency lifestyle is a little different. You get long hours at the hospital, but it is rewarding. There's a lot of learning opportunities, doing surgery, going on, rounding on the patients. We have multiple clinics. We have an emergency clinic. We have a clinic at the dental school that we see kind of more private practice type patients as opposed to emergency setting patients. We see patients in the trauma bay, typically interns that carry the pager, and we'll see consults both in the main ED as well as the fast track and in the trauma bay. So we take call. We have lectures. We have Wednesdays usually our academic day, and where we take kind of lectures. We have a journal club that we participate in. We attend lectures. It's only I think a couple hours a week, so it's not really a lot of lectures, but a lot of it's independent learning. We take an exam, an OMSITE once a year that is kind of just like written exam that every resident has to pass before getting the certificate. And yeah, the nice thing is the GME funding that we get paid as residents. Not all dental specialties residents get paid. So it's really nice that we get paid finally after so many years of paying massive amounts of money and having tons of loans. Still have tons of loans. Hopefully Biden changes that. So next steps, how do you prepare for oral maxillofacial surgery residency? Do well in dental school, or if this is interesting to you and you're in medical school, well, ENT, like I mentioned, and plastic surgery have a lot of overlap. So I encourage you all to follow your passions, follow your goals, don't give up, and do externships, get as much exposure as you can to the field that you're interested in, no matter what the specialty. Really, find out if oral maxillofacial surgery is for you, and this applies again to all specialties, but, go do some rotations, see if it's really what you like. It's obviously not for everyone. You really have to be passionate about it to withstand the, grueling years of residency and taking call and late nights in the OR. But if you enjoy it, it's really not a burden, and you have to just really be in it for the right reasons. So, and this way you also find out which programs, every program is different. You find out which program, which type of program appeals to you, and what, and where you'd be happy. There's a lot of factors to take consideration. That's a whole presentation in and of itself. And this is the exam that I mentioned, the Comprehensive Basic Science exam. It's also given by the National Board of Medical Examiners, the same that give out the step 1. So all OMFS applicants have to take this exam. This is probably the single most important factor when it comes to assessing the application. So really give yourself a lot of time to study for this. Again, it's exactly the same material as the step 1. So same question types, just as difficult, just I think one section less. And this is really the single biggest kind of hurdle on your path to becoming an oral surgeon. So it's intended to allow a fair and standardized comparison. Again, there's many different dental schools out there. So for program directors, it's really one way to standardize everything and be able to compare applicants. Although I'm not a big fan of it, I do see the need for it. So yeah, there you can find out more by visiting the AAOMS website. That's the American Association of Oral and Maxillofacial Surgeons. This presentation was actually given to me by them. I'm one of the members of the Residents American Association of Oral and Maxillofacial Surgeons, and definitely encourage you all to head over to their website if you want to learn more about the specialty. And there's a lot of great resources on their website. And here they are. If you want to write these down or take a screenshot, or you can just Google anything these days. Okay, now it's a little bit more fun stuff. I talked about my Instagram, but these are other Instagram accounts that I kind of recommend to follow if you want to learn more about oral maxillofacial surgery, or as Megdi mentioned in the beginning, some people that like to watch, kind of wisdom teeth being extracted, popped out. There's Bloody Tooth Guy is one of the best accounts to follow for that. He has one of the biggest accounts on Instagram. So I also recommend, like I said, the Rutgers OMFS program page that you could see more of what we do at our particular residency. This is the Smile Bangladesh. That's the cleft lip and palate mission trip that Dr. Aziz runs twice a year. It's really a great cause. Please give them a visit, give them a follow, and donate if you can. It's really a great cause, and it's all done through funding by people like you. Bloody Tooth Guy, like I mentioned, is that bread and butter dentoalveolar private practice surgeon, as well as PNWOMS, that's out northwest, out in Washington. Stone Surgical Arts, she's does full scope OMFS in Texas. She's a great account, very educational. I love following her, as well as Dr. Jackie. They do kind of joint post collaboration every Tuesday called Tuesday Truths. They talk about various medical and dental and oral maxillofacial topics. And she's in the academic setting in Ohio. Rania Habib as well. She's a fellow Arab American Muslim that is at Penn, and she is on staff there as an oral maxillofacial surgeon. She specializes in craniofacial surgeries. So God, give her a follow. She's a great big advocate for women in surgery as well. Definitely, again, stress the fact that everyone should follow their dreams and aspirations and put aside any society kind of don't let people's opinions influence you. If that's what you want to do and you're passionate about it, pursue it. Definitely underrepresented women in surgery in general. And again, love to see more. This year, actually, 2 out of our 3 matched residents are females, and I'm really proud and happy of that. So other accounts, like I mentioned, Vegas Max Face does full scope OMFS, really great account. Definitely should follow him, as well as hashtag OMFS. He's a dual degree MD and DMD that does a lot of microvascular and treating cancer. Badass account. And last but not least, the Alabama Surgical Arts. He's a Rutgers alumni from our residency program that's in Alabama currently, specializing in cosmetics. He has also a med spa that he runs with his wife. Again, great account, does live surgeries, facial cosmetics. If you're interested, give him a follow. There's so many accounts out there, so many educational content. I learn a lot through these accounts, and definitely encourage you all to give them a follow, really enrich your feed. Thank you all for listening in on a Wednesday afternoon. If you want to learn more, follow me at All Day OMFS. Got right here, click the follow button, and we'll open the floor to any questions.
I want to first. Oh, sorry.
I'll stop the share.
I want to thank you for an amazing presentation. I wasn't aware of like how OMFS was like almost a walking hospital. All the things you guys do, especially like oncology and ENT and even plastics. So that was really amazing. And make sure to follow his account. We'll link that in the chat, and it's on our Instagram and everything. We are running a little close to the end of time. So one question that we like to ask all of our physicians that come on is, if you were in a place of undergrads right now, or even medical students, what's the one biggest piece of advice you would give somebody in that position, or maybe even a younger version of yourself?
Yeah, like I mentioned multiple times, it's that literally do not give up on your dreams. Don't have a second option. If you're determined to do something and you want to do that, don't let there be any any other options. Go for it. And I was telling you guys before, but I'll mention this story now, is basically I had a tough time both getting into dental school and into oral surgery residency, but I just kept at it, kept grinding. The first time I applied to dental school, I didn't get accepted, but instead of letting that deter me from what I wanted to do, I found out what are the steps I have to take to better my application, to better my chances. I did the joint master's program at Rutgers, while also pursuing like shadowing opportunities. That's where I applied to every dental assisting position in the area, for every specialty. It didn't matter. I wanted to get into dentistry, and I so happened to be employed by an oral and maxillofacial surgeon, and he really opened my eyes to the field of oral and maxillofacial surgery. And like I mentioned, when he took me with him to the OR to do an orthognathic case, I was blown away by the scope of practice and sold on it right then and there. And I retook the DAT, which is like the MCATs for dental students, and I blew it out of the water and got in the second time around. But I had to wait 2 years after applying the first time before I got in. And then after dental school, again, same thing. I applied to oral surgery and I didn't get in, but I did what's called an internship. In medicine, it's more like a prelim year. I ended up doing it at Rutgers, and even after doing one intern year, I still didn't get in. I did another intern year, and then I got in finally. And let me tell you, it's all worth it at the end of the day. I can't see myself doing anything else or anything different. Don't let the years and the time deter you. Really, life's a journey. And at the end of the day, if you're doing what you love, you're going to enjoy every step of the way.
It was beautiful. Thank you so much. So we're gonna send the quiz and the journal entries in the chat. Make sure to fill that out. Take your time and really reflect on the presentation today and what you learned, so you can get the most out of the experience. We will be back next Monday with Dr. Thom, who is an infectious disease physician. We have all that information on our Instagram, and we have all our links on our link tree. And we again want to thank Dr. Abushanab for coming and everything that he's revealed to us today.
All right, great. Thank you guys. Really